Any issues?
Just a minute, sir.
Okay.
So we are live now.
Okay. Good evening, everybody. Today we are having a webinar specially for ILIZAROV and other fixators around ankle and foot. And we have an eminent faculty from Brazil, Helio, Cunha, and he has consented to present his work on CTEV, neglected CTEV. And we have our eminent faculties like Cherry Sir, Madhura, Siddharth, and Aradhana, not to forget. They'll also be sharing their inputs. So without wasting time, I'll hand over to Akanksha to give a short, brief description, introduction to Helio, and then we start with the presentations.
Good evening. I'm sorry.
No worries. Good evening, respected faculty members, dear friends and colleagues. Very, very happy to introduce Dr. Helio Cunha Neto, MD, and from Brazil. He is a chief orthopedic trauma surgeon and a limb lengthening surgeon at the municipal hospital in HMCC, and he's also he also does limb lengthening procedures at Unife SP from Brazil. Thank you, sir, for joining us.
Thank you. My name is Helio. I'm from Brazil. I'm assistant here in São Paulo. I'm from the Federal University of São Paulo. São Paulo is a big city, not as big as Mumbai or other Indian cities, but it's a big city. We have some experience with external fixation and in limb lengthening. I'll present today my experience in neglected clubfoot in it's a two-step neglected clubfoot correction. Let me share my screen. Okay, so I'm from the University of São Paulo. It's one of the biggest universities in Brazil. We are from the Department of Orthopaedics and Trauma. Here's our hospital in São Paulo. So I'll start the presentation about the two steps correction of neglected clubfoot. So I think the experience with neglected clubfoot in India is very similar to Brazil. We still have a lot of untreated patients with clubfoot. The clubfoot is a common condition in I think in every country, but it's harder to treat in countries like ours with poor conditions. It's a congenital deformity, usually bilateral. It has a lot of environmental factors associated with like oligodramio, poor conditions, use of alcohol during the pregnancy, and the most common deformities, the cavus, adultus, varus, and equinus of the foot. The neglected clubfoot is a clubfoot deformity that was never treated. It's not common in richer countries, but in undeveloped countries, it's more common, and it usually leads to a compromised gait. So the most common sorry.
Akanksha, mute everybody, I think so, except the speaker.
So please,
Can I keep?
yes, please go ahead.
So the compromised gait is the most common complication of the disease, usually associated with pain. So I have a case of a patient with 13 years old, treated with an external fixator in a two-step correction. So it's the clinical presentation of the patient. It's a classic clinical presentation of a neglected clubfoot. So I can show you guys the guide of the patient. He's adapted with the condition. The X-rays are almost common. There are some deformities associated from the untreated condition. Most commonly, the talus being in a different position from the normal foot. You can see he has like a flattened talus, almost parallel to the calcaneus and the equinus of the forefoot. So to treat in a two-step unconstricted correction, we use, in this case, a pure articular extraction. I didn't do any osteotomies. We had two blocks, one in the tibia and one in the forefoot. We use the coronal axis for lengthening in the long axis of the member on the first step, and I use it two distractors. Some colleagues from the university, they usually use three distractors. I used only one, and the rhythm is tailor-made. We do the rhythm. We dictate the rhythm based on the patient clinical response. So that's the first presentation of the frame. We use I used two cardan axis, the multiple two cardan axis hinge, two multiple axis hinge on the forefoot block. The clinical presentation of the patient in the immediate post-operative. So the main goal in this kind of frame is to elongate the foot on the long axis, almost like the first step of the Ponseti method. So I can have the articular distraction, and I can use on the second step the fixation of the hindfoot. In these cases, to connect the tibial block to the hindfoot, we have some difficulties. So that's why we use the two-step correction. So the clinical management, we do pure articular distraction. We do it faster. And one of the main things we have to care about during this step is to evaluate the blood supply of the plantar foot. Some patients they present with discrete ecchymosis of the plantar foot. So when presented that way, we usually reduce the speed of the distraction. We correct the adductus and the varus. We do the radiological evaluation on every clinical evaluation. And one of the possibilities during the treatment is the material failure because of the strength of the distraction. So it's a photo of the clinical presentation of the patient during the follow-up. As you can see, he didn't present the plantar ecchymosis, but the material was starting to fail. We see that because of the distraction strength, the ring started to deform, as you guys can see here. So we do the second step. The patient present with greater articular elasticity, and in that step we fixate the hindfoot. We do the hindfoot and the forefoot connection, and we start the equinus correction. One of the main questions, the main argument contrary to this kind of correction is the claw, the finger's claw, the possibility of the finger's claw. So some colleagues, they usually fixate the pododactylus. Here is during the procedure, as you guys can see. I'm sorry, the patient presented a good lucidity of the articulations, making it possible for some acute correction. So the immediate post-operative image of the second step, as you guys can see, he had already some correction of the equinus. So the management of the second step consists mostly of the equinus correction. We do the final midfoot adjustment. You can elongate the adultus, and we discuss with the patient the orthotization, the casting. After the correction with the clinical assessments, as you guys can see, we had the correction of the equinus, and the adultus was corrected also. The radiographs, he also presented the correction in the X-rays. So we discussed the removal of the frame. Here in Brazil, in this kind of corrections, we usually do it in the surgical center. We usually cast the patient. We try to maintain a hypercorrection positioning, and we manipulate the pododactylus to at least try to correct the claw. So the clinical imaging of the postoperative after the removal of the frame. This is the immediate post-operative imaging, clinical image. So the follow-up after the removal of the frame is also very important. We discuss how long it's a discussion for how long we maintain the hand molded cast. We discuss with the patient the possibility of bracing and for how long we will maintain the bracing and the correction of the residual deformities. So the first clinical assessment in the post-operative of the removal of the frame. Here, after a month of the removal, it's not a normal foot, but with the plumper presentation of at least a normal gait. And mobility on the pododactylus. He, at least for the 6 months, the first months after the treatment, he used this brace for the maintenance of the position of the foot and ankle. So some considerations about the technique. It's a closed procedure. I usually, on younger patients, don't use osteotomies, but in older patients with more severe articulation alterations like osteoarthrosis, we can associate osteotomies. We leave a question for how long should we keep the bracing? It's an important question we do ourselves when we treat it this way. It's good for the patient acceptance. It's easier to treat like this, I think so, because of the faster procedure. We don't do incisions, and we can discuss what else can we do in this kind of techniques. Other thing we can discuss is that we can preserve for longer the original biology of the patient. We don't have to think about arthrodesis in this kind of technique. We usually in our group we praise our boss, the Dr. Lario Boato, who passed away in 2021. Thank you, guys.
Hello.
Yeah, I'll talk.
This is Dr. Helio. This is Dr. Altaf Krawusa from Srinagar.
Hello.
Am I audible?
Yeah. I can hear you.
Yeah. It's a nice presentation. I have few concerns. Like first, you try to do it in 2 stages.
Yeah.
Okay.
Yeah.
So the forefoot frame and the tibial frame. How are you able to manage a distraction of the forefoot? Because
Um,
biomechanically, the distraction forces are in a different way. I would have preferred that should there have been a calcaneal ring or a calcaneal half ring or an arch.
yeah, the idea in the two-step correction is in most cases they have atrophic calcaneus, and there's a difficulty fixing the hindfoot.
No,
So
you see, I get it. I tend to do this as a single stage, single frame construction. So my
Yeah.
frame is a little different. So
Yeah.
I do base it totally on the basis of Ponseti. So what I do is that the tibial frame is same. So what you do, you maintain a good distance between the distal ring and the calcaneal ring. You can use an arch or calcaneum in the same equinus position so that there is enough space left between the distal ring as well as the calcaneal ring. Then you use hinges on the posterior aspect for correction of equinus. So what my take is that I do it totally on the basis of Ponseti on single frame. I don't have to do it in 2 stages. In stage
Yeah.
one, I use the distal arch like you use in the forefoot, but I distract between the calcaneal ring and the forefoot ring. Based on the Ponseti, I use a talar pin that fixes
Yeah.
to the proximal finger. Maybe this time I'm not ready, otherwise I would have demonstrated it on my screen. So that gives me an advantage that you are able to do it on the basis of Ponseti, that you use calcaneopedis block against the talus. So the foot rotates on this. So while I was looking at the X-rays of yours, so there is more of a spurious correction rather than an anatomical correction. Perhaps because of that, because the way you are distracting at quite distance from the tibial frame and in two different planes. It's not in the like 4-foot adduction would have needed a plane that would be corresponding to the calcaneus. This is my
Yeah.
take.
Yeah.
So that is why.
It's not the. I'm sorry.
Please
Go
go
on.
ahead. Please go ahead.
No. It's just an alternative to the regular frame configuration we usually do with the hind foot block and the forefoot block connected. But this kind of correction is an alternative to the classic.
Absolutely. I get it. But only thing is that it's biomechanically, it doesn't look to be so appropriate because you have the tibia in one plane as well as the
Yeah.
forefoot in the different plane. So what you are intending to do is with medial differential distraction, perhaps that the plane of deformity correction does not remain very effective.
Yeah.
That's my only concern. Maybe I
Yeah.
can, my paper is under publication. I'll share that. So perhaps that might give an idea because that way I don't have to use a second stage. Absolutely, I don't use any second stages. The frame is constructed absolutely on the basis of Ponseti. Because it will be hard to explain by words. If I get time and if I find in my phone, I would just share one X-ray so that perhaps that might be helpful to the audience as well as in explaining my point. Excellent
Yeah.
presentation. Anyway, excellent presentation.
Thank you.
Thank you.
There are a few questions in the chat box and YouTube. Akanksha, if you can take them.
Let me
Yes,
check.
sir. Cherry sir wanted to ask a question.
Go ahead.
Cherry, sir.
After the frame removal, do you do a tibialis anterior transfer to prevent the recurrence of deformity?
I don't do any transferences, any tendon transferences in this case. If the patient presents some operations, we can associate some transferences, but I don't have the experience with the TBL transference, anterior TBL transference.
There's a question by Dr. Reddy also.
Yeah. What are your indications of osteotomies and what type of osteotomies do you go for?
Usually on older patients, I tend to do the midfoot osteotomy. For in these patients with the pure distraction, they tend to deform after the correction. So on older patients with with arthrosis and more severe alterations of the talus, I tend to indicate midfoot osteotomies. On that case, on that younger patient, I didn't do any osteotomy.
What type of midfoot osteotomies?
I have the lateral to medial midfoot with osteotomy and I can we can use in my.
So I think there are some signal issues at his end.
There is some network issue, it seems.
Seems to be some network issue.
Yeah.
I just have one thing in my mind. We keep on doing. Am I audible?
Yes, sir, you're audible.
We mostly treat these cases in case there is a wire is passed from the talus, so that we maintain the biomechanics like Ponseti. But the question is, in most of these cases, they are already operated twice, thrice by open medial releases. And the scars, they are too adherent to allow any movement of the calcaneum. So I think in these cases, Ponseti doesn't hold good, and you have to do the correction forefoot as well as hindfoot separately, side by side. This is my view. I will like if the suggestion of the what is the opinion of the most of the senior people about this, because the adherent scar on the medial side hardly allows any motion of the calcaneum. Good evening, sir.
Vasu sir, your comments?
Yeah, I think we have to. It's a nice presentation, Cunha. It's good. But for teaching purpose, I think we have to approach the situation a little more critically. So we have we have to evaluate the deformities. So we have a hindfoot deformity like equinus, which is around the rotation of the talar body. So I think as Bola said and Altaf said, normally we do like him, we put a frame for the tibia, and you always keep a little distraction hinge for the ankle, and they correct the circuit in a TAT anatomy. So that will correct the talus, calcaneum. Talus is a poor bone which doesn't have any hold on its own. It has no choice of movements because that guy is always blocked by medial malleolus and lateral malleolus from both sides of the ankle, and under surface you have calcaneum. Whatever the calcaneum and medial malleolus and lateral malleolus says, the poor talus follows that. So you don't have to worry about any pin in the calcane, the talus. In Ponseti, we do that as a hinge in a closed correction. In ILIZAROV, you don't need, you have to calculate, you can do the reverse thing in the calcaneum. So that is what I do it. I have a strong frame on the calcaneum. With a hinge, I pull it down. So with the separate fixator for the leg, heel and forefoot, we can differentiate define all the deformities. Like pronation can be corrected, adduction can be corrected, and adductions and cavus can be resolved into an oblique plane. And if you want, you can put a hinge and correct that in a single. And if you want, you can put a full ring in the forefoot to give a little more stronger, like in a burn contracture. Because the deformity cause can be anything. It is just a TEV. It need not be CTEV. It can be anything. Let it be post-burn, let it be post-scar, whatever. You define your deformities, assess what are the components of the deformity, and correct each component systematically and correct. And when the bone is deformed, so don't go for only soft tissue correction. You can do a osteotomy correction. Generally, in the CTVs, the osteotomy corrections are rare in younger age because the bone can still grow. In an old age patient, usually we do a osteotomy corrections. But overall, the frame is the same. A 4-foot frame with 2 to 3 wires, calcaneal oleo wires and wire and a pin, tibia as usual normal. And the trick is you keep the tibial frame, as Altaf said, little proximally, so that you have good space. Cunha, you have done a wonderful job, but only thing you try to divide each one, but that's a personal choice. You can divide 4-foot separately, hind-foot separately, but we usually do in one stage.
Just to add up, because there will be many beginners, whenever you hold the tibial frame to the calcaneum frame, the rods should be distal and they should be far away from the calcaneum, so that once you distract, there's no ankle subluxation.
No, so Bola, the problem is you keep a hinge from the tip of the medial malleolus to the tip of the lateral malleolus and a centimeter anterior to that. And imagine you have a circle around that. Your distraction should be always along the tangent, along the circle, tangent. So it comes from the tibia medial inner side, calcaneum it goes outside. You never distract straight downwards from the tibial frame. That is the point.
But
Huh?
I say the rod must go posteriorly on the calcaneum
Obliquely.
rim.
It should go
Obliquely.
obliquely.
It must go obliquely. Otherwise, there
Yeah.
will always be a strain on the ankle and it will try to subluxate.
And whenever you do the corrections, the hinge, around the hinge, the retractor should be around the tangent. Everywhere. Let it be
Once you have the hinge, once the hinge is not there,
then you need two distractors.
two rods posteriorly.
No, then there is an imaginary hinge.
Yeah, yeah.
Around that you can calculate. You can keep, that is called, you have a constrained correction, you have an unconstrained correction. Constrained correction, you put a hinge. Unconstrained, the body acts itself acts as a hinge. So in that case, you need two
Once
distractors.
it is once it is
Last-
unconstrained, then the rod should be posteriorly
In
on
both
the calcaneum ring.
In both cases.
Okay.
Even
Yeah.
constrained.
Dr. Bola, it's always better to use hinges in the way, because if you are tending to correct a deformity, then straight rods are going to bend,
Yeah.
because somewhere the correction has to happen. It is the hinges that allow it to rods not to bend.
It
So if you are
avoids,
moving it, yes, like
yeah,
boss
it
is correct.
reduces the crushing.
Because if
You are
you
right,
tend to
the
use a
hinge.
straighter rod on a curved thing, then
Okay,
it
sir,
has to come out in the bend, has to come out in the rod.
Yeah. It reduces the stress on the articular cartilage.
Of course, of course.
moving on to the next speaker, Cheriyan sir, because we have a time constraint also. So sorry for interrupting in between, sir.
Yeah, I'm sharing my screen.
Yes.
We're talking about bone loss around the ankle joint. A rather unusual problem, but quite difficult to manage many times. 1 minute, yeah. Now, what I'm going to discuss is the problems of bone and soft tissues, management of bone gaps, types of ankle fusion, methods of ankle fusion, what would be the best option, and how good are the long-term results. Now, the problems we face are infection, bone loss, osteoporosis, deformities, mainly equinus, comorbid conditions, neurovascular deficits, and scarred soft tissue. Because all these problems, these are the problems we face when we're doing a distal tibial bone loss management. Can everybody see my screen?
Yes, sir.
Can you see the screen?
Yes, sir. Visible.
Okay. Now the problems and deformities and soft tissue loss are the soft tissue problems. Deformities basically equinus and soft tissue loss around the ankle, sometimes around the tibia also. And the bone loss either can be primary or due to infection. It can be either ways. Now, what are the types of bone gap? We have either the loss of distal tibia and fibula, Paulo part, or loss of talus, or loss of distal tibia and the talus also, as shown in the picture. So the questions to be answered are: what can be done? Is reconstruction possible? What is the best method? And what is the ultimate function after reconstruction? Is reconstruction cost effective, or is amputation better? Because many people still believe in amputation. So the aim of treatment is, in these cases with bone loss around the ankle or infected ankle, is ankle fusion. How do we achieve that? There are various methods. The most common is bone transport. The other is bone grafting, either vascularized or non-vascularized, which can be either cortical or cancellous. Now, when you have problems like bone and soft tissue defect, shortening, deformity, and infection, the only one thing handles or addresses all these problems is the bone transport, nothing else. So the methods are bone transport, either external fixation or combined external and internal fixation. Now, the bone transport is basically done with the ILIZAROV ring fixate. I prefer that. And I don't think any other fixator matches that the ILIZAROV IN fixator for especially bone loss around the ankle. It manages osteoporotic bone, it manages small segments of bone, and various configurations are possible subject to safe zones. It's a very versatile fixator, in other words. Now, the procedure is debridement intersection of necrotic bone and soft tissue, denudation of whatever remains of the tibial, talar, or the calcaneal cartilage, and frame application. Now, what is the position of fusion? It should be neutral valgus and varus and rotation. Neutral dorsiflexion and plantar flexion, although some people disputed that some amount of dorsiflexion and some amount of plantar flexion can be given. But the other thing is midline of the tibia should be in line with the lateral process of the talus or sinus tarsi. That's very important. Otherwise, you will have an L-shaped foot. Now, the frame application is 1 to 2 rings proximal to the tibia, in the proximal tibia, proximal to the corticotomy, wires and half pins, with wires and half pins. Again, 1 to 2 rings in the distal part of the leg. That's a middle block for transport. And in the foot, 1 to 2 wires in the hind foot and forefoot, with a talar drop wire and a hind foot calcaneal pin. Now, the hind foot calcaneal pin is extremely important because that gives the most stability. Now, osteotomy or corticotomy can be done in the proximal tibia, but sometimes in the diaphyseal corticotomy, it maybe have to be done if the proximal corticotomy is not possible, or you're planning for 2 corticotomies. Now, weight bearing is as tolerated. You never tell to the patient full weight bearing. You just tell him, and I always tell my patients, you weight bear as you can tolerate. That's it. And the bone and soft tissue defect in the same place, same site. You don't need a flap cover because as the transfer proceeds, automatically the bone and soft tissue defect closes. Now, why ILIZAROV? Because that is one thing, it's got a good bending and torsional stiffness, but at the same time, a low axial stiffness. So compression can occur, end-to-end compression can occur. That's what makes ILIZAROV fixator unique. Now, this is a 9-year-old boy who had a fracture, closed fracture lower third tibia, treated with kiri. It means otherwise hot massage. The fibula got exposed. Some surgeon excised that exposed fibula, and the tibia got also exposed. Now, with the result that when the patient presented to us, you can see the tibia and the talus also. So we are not sure whether the calcaneum also would be going, and this is how he was walking. We are not sure whether the calcaneum would have also was necrotic. So we told him, in case the calcaneum is necrotic, we'll have to amputate it. Anyway, the even most of the talus also was viable in spite of the horrible appearance. And this is the frame, double level corticotomy, 6 centimeter bone defect, double level corticotomy. Although many a time we don't need a double level corticotomy, I just did it at that time. This is a double level corticotomy, bone transport, docking. That's a union. It's a union. And that is almost normal gait now with the solid angle fusion. Now, another 33-year-old fellow with loss of talus, post-traumatic. So, this was the after debridement and frame fixation and double level corticotomy because a 7 centimeter bone gap was there. Again, I'm repeating that you don't really need a double level corticotomy. You can manage with a single level corticotomy. Although I feel double level corticotomy just shorten the time a little bit. That's docking, union, and this is the end result. It's climbing up and down stairs independently. So a lot of others have published it. And the union rates are between 80 to 100% in most of the articles. And we have published our results in 2009 JBJ's March. And we had a fusion rate of 95% and mean follow-up of 52 months. And by Hawkins criteria, good and fair, we had 80%, 85%, and return to work 80%. We had a few complications, but all of them were managed successfully. Now, is ILIZAROV bone transport the only option? No. The vascularized fibula graft A non-vascularized fibula graft is a cortical cancellous vascularized bone graft, vascularized and non-vascularized graft with ILIZAROV ring fixation, and transport over IM nail. These are the other options. Now, non-vascularized bone graft, cortical bone graft is not a good option, especially when there is infection. Maybe it may work for children without at least quiescent infection, but in adults, it's a high incidence of failure in infected cases. Non-vascularized cancellous bone graft, CNE has published a series with 92% fusion, but the disadvantage is you need a huge quantity of graft depending on the size of the defect. Vascularized bone graft, mainly vascularized fibula, is a single-stage procedure. There is no need of prolonged frame where the graft hypertrophy is in the response to load bearing, but shortening is not addressed. There are stress fractures, non-union at the graft host junction, and further deformity correction is not possible, and long period of hypertrophy taking up to 18 to 24 months. So combination of vascularized bone graft and ILIZAROV, we thought early weight bearing and early hypertrophy, but unfortunately it didn't happen because the frame was protecting the graft. So the graft was never mechanically loaded by itself. So it never could hypertrophy like as we expected. Only after frame removal, the graft really hypertrophied. Transport over nail published by Leventer Lab from Turkey. The advantage is reduced external fixation time, but in infected cases needs additional procedure to eliminate infection. Sometimes you may need multiple procedures to eliminate infection before you can put in the nail and then put in the ring. So the concept of external fixation index, our series, that is the external fixation index is the time on the ring fixated by the amount of bone loss or shortening. So our series matches with our result matches with the international, the published literature. But bone transport over IM nail, the external fixation index is much lower. But the problem is you need multiple procedures again. So bone loss, shortening, deformity, infection. The only thing that can handle all these problems together is the ILIZAROV ring fixator. Now, what about the long-term follow-up? This is a patient who had an ankle fusion, 10 years follow-up, 20 years follow-up. This is another fellow with 17 years follow-up, 17-year-old male. See the subtalar joint open, joint is present. This is 18 years later in 2022, walking normally, but the subtalar joint is fused. So we did a study again on spontaneous fusion of subtalar and metatarsal joints in ankle fusion with ILIZAROV ring fixator. We and some colleagues from Korea did the study together, and we found out that tibia-talar fusions with there is a 29% incidence in subtalar fusion, and a subtalar and metatarsal fusion, there's a 56% incidence, and tibio-calcaneal fusions, 100% incidence in metatarsal fusion. But the interesting part is these fusions were asymptomatic. As far as the patient was concerned, he never noticed it. We just found it incidentally on X-rays only after long-term follow-up. So is amputation superior? 2-year outcomes are same as reconstruction, and reconstruction leads to lower lifetime costs because the cost of the processes is not factored into account. Now, indications for amputation: unsalvageable foot, loss of calcaneum, patient not fit for any reconstructive surgery, associated neuropathic feet, or poor vascularity in the foot, but the decision is always individualized. So in conclusion, ILIZAROV ring fixation, it's universally addresses all the associated problems, good results in the long term, but the problems are learning curve and complications. And interestingly, subtalar and metatarsal fusion, which is asymptomatic. Thank you.
Thank you, sir. There are a few questions in the chat box. Akanksha, if you can take them.
Yeah, 1 minute. Yeah. Okay, chat box.
Yes, sir. Dr. Premchand is asking as to from which day, sir, would you advise patient for weight bearing after the surgery?
No, weight bearing is done as tolerated from the second day itself. From the first post-op day itself, we allow weight bearing as he can tolerate. We don't say full weight bearing, 50% weight bearing and 30%, nothing like that. As he can tolerate, he can weight bear.
Okay.
Okay. No other questions? Then we move on to the next speaker.
Just two, 3 points, sir, with your permission, sir.
Sure,
Yeah.
definitely, sir.
Ankle fusion with ILIZAROV gives you 3 dimensions. One thing, that you can correct post-operatively equinus or calcaneum. What does that mean? If there is slight equinus, that will put a knee in hyperextension. So you have to keep this thing in mind. If there is more calcaneum and it is without ILIZAROV, that will produce in the knee a hyperextension strain. But with ILIZAROV, you can avoid that. Similarly, in the calcaneum, the knee will start buckling in case it is fixed without ILIZAROV. So with ILIZAROV, you have the option that you can post-operatively manage and find out the exact endpoint where this plane, sagittal plane, should be there. One thing. Second thing, the rotation of the leg, that can also be tackled with the ankle fusion with ILIZAROV. Sometimes tibia is externally or internally rotated, and that produces unnecessarily in the knee locking or unlocking. So you can rotate the tibia accordingly so that it is almost in the axis which is desired vis-a-vis knee joint. Thirdly, the tripod varus or valgus, that can also be postoperatively manipulated, and the foot exactly can be planted in the plantigrade position. And fourthly, mostly slight posterior translation of the whole aspect should be done so that the gait is better. Thank you.
That's what I said. The midline of the tibia in the lateral view should be in line with the sinus
Exactly.
fascia in the lateral.
You have already explained. Thank you, sir.
Thank you.
So there's another question. During fusions, bone graft is necessary or just compression will be fine, sir?
Yeah, you mean whether I do bone grafting?
Yes, sir.
Yeah, previously I never used to do, but nowadays I do. When it docks, I just make a small incision, take the patient to the theater and make a small incision and put a little bit of cancerous graft. It makes the union faster. You can clear the fibrous tissue, intervening fibrous tissue also. This I learned from Professor Katani. Because he always, when the bone ends dock, he always used to do a bone grafting. So it's better to do a bone grafting.
Yes.
Moving on to next speaker is Siddharth there.
Yes, sir. Sir said he'll try to present, sir.
Yes, sir. So I'm having trouble with the network, sir, but I will try to present. So, Akanksha, is my screen visible?
Yes, sir. Your screen is visible.
Okay. Yes, for this wonderful opportunity. And I'm going to be talking of a slightly different topic here, which is virtual surgical planning and how we can apply it in our clinical practice. Okay. Yes. So the objectives of this talk is to tell you what is a virtual planning, how do we apply it to our practice, and then what are the pearls and pitfalls. Now, mind you, this is not a step-by-step approach lecture. Like they say in the matrix, it is just intended to show you the several possibilities. So what exactly is virtual planning? So it is use of 2D or 3D images to evaluate complex anatomy and guide treatment. And I like to think of it in terms of visualization, measurement, and virtual surgery. So how can we visualize? Now, this is the case of a talus malunion, and you can see that this patient has a cavo-varus deformity. And we keep saying that we should fix the talus neck well. But how do you know what is the amount of varus? So, in this case, we took an extra section of the CT scan. We can draw the mid-axis of the talar body like that. Then we are also able to draw a mid-axis of the talar neck, and we can actually quantify the amount of the varus and what correction is needed. So all of this is only possible if you have a software known as a DICOM viewer. Now, torsion is a very difficult deformity to define. And how do you quantify torsion? Right? So in this case, we see a section of the talar body and we see a section of the talar head. Now we can superimpose these images on top of each other, and then we can actually see this is the talar dome. We draw a line here. This is the talar head, and again we are drawing the long axis, and then the angle between the two tells you the talar torsion. So this torsion principle the same principle can be applied to femur, tibia, or any other bone for that matter. And then with augmented reality, so this is a video that I shot in my room with a standard iPad. So you can actually project that 3D model onto your surroundings and you can visualize everything in 3 dimensions in real time. Now, how do we measure? Now, measurement is something which we've been doing routinely. Some of you have also used the bone ninja deformity, but can we automate these measurements? So there is a very good software by the name of GeoGebra. And here you see that we have designed a custom script. So you just click some points on the CT image, right? There you go, 6 points on the talar head, 2 points on the talar body, and you can create custom automated measurements. The user still has to enter some of these points. Now moving on to volumetric measurements. So here we see a case of a giant cell tumor which got infected. The implant was removed and ILIZAROV fixator was put. Infection subsided. We want to bone graft it. What is the volume of bone graft that we should use? So in this case, we use this Horos DICOM viewer, which is a freely available software. You will see that I am marking out on one of the sections. I am just marking out the defect. The defect has been marked in red here, and then we can tell the software to compute this for all of the sections in the image. So as soon as I click image, OK, the software is computing, and now it has calculated the volume of all the defects, of the entire defect in the area, and it gives us a very good idea of how much bone graft we should use. Can we do virtual surgery? Well, yes. So here is a calcaneus fracture, which is a tongue type fracture. And this is a freely available software. It's called Sketchbook, right? So in this software, you can actually mark out the posterior facet of the calcaneus. So I'm just taking my cursor and I'm marking this out. The same principle can also do a variety of deformity correction procedures. So I'm just very, very carefully marking out the outline of the calcaneus. Once that is done, I can then rotate this. So as you can see here, now I'm rotating the fragment to get a perfect reduction. This gives me an idea of what the reduction should look like. In a deformity correction case, I can also see what my corrected deformity would look like, right? And then this is not all. You can also import the image of a plate, as you will see now. So we can go ahead and import the image of a plate. And you are able to overlay this. So you can shrink the plate, you can fit it, and you can plan everything. So virtual osteotomy with Bone Ninja, so you can design the osteotomy, you can simulate your corrections. This is a 2-dimensional planning. But what if that this can also be 3-dimensional? So this is software by the name of Mesh Mixer. And then selecting this digital fragment, you are able to rotate that fragment in 3D. Right? So of course you have to choose your hinge point, you have to see where you are translating and whatnot, but it is able to correct this in 3D, and also you are able to put implants on this and plan out your entire surgery. So here's one practical example. So this young girl came to us with a post-traumatic cavovarus deformity of the foot. The radiographs show you that there is a talar injury, there is something going on. The CT scan shows you that there was a talus neck fracture, which has not united. The CT also shows you. But here we have taken a 3D model of a talus of the affected side, which is the red side, and superimposed it on a mirror image of the normal side, which is the white side. And you can see that there is a little bit of a varus deformity. But then you can also see that there is a dorsiflexion, torsional deformity, and this actually tells you that this is a three-dimensional deformity. So in this case, we did an open approach to the subtalar joint from the lateral side, reduced the subtalar joint, fixed it, and got a very, very good correction thanks to our preoperative planning. The fracture united, and we got a good deformity correction. So this is not really an ILIZAROV case, but it just shows you the principles that can be used to plan out our deformity. Now, if you want to use all of this software, you have to get the raw data, which is a DICOM file, right? You don't use the images sent on WhatsApp. You have to learn a little bit of a segmentation technique. And then some of us are used to 2D planning, but the more that we get into 3D planning, the more accurate it becomes. Pitfalls are, yes, it does take time, but it gets better. You should not rely too much on 3D models because, especially for measurements, because they are rendered from the CD and they can have some inaccuracies. So for measurements, I would say that CT scan is still the best, and 3D models do not account for joint range of motion. So there is a concept of a 4D model. The fourth dimension is the time here. So over a time, how a bone is changing or a joint is moving, that can also be factored in. So the take-home message from this presentation is that virtual planning is a must. We are planning in 2D, but we should also learn to plan in 3D. It is a skill that we can learn very, very easily. After all, we are all ILIZAROV surgeons. So planning is iterative. And I love the saying by John Herzenberg, who said that measure thrice, but cut once and get that precision in your surgeries before you execute. Thank you so much. Thank you for your time. I'm going to stop my screen share.
Thank you, sir.
Yeah. Any questions from the audience or any comments from the faculties?
That was a beautiful presentation, but my request is this talk available on YouTube or somewhere, or you can share on the ASAMI, because there were many softwares which one is very, it is
Yes,
difficult
Bola
to
sir,
remember.
I will be happy to share an article or a PDF or something with all the links.
Because I think this is the future of where we are doing nowadays. It is a future of these kind of planning on 3D, especially how to cut, how to rotate, how to angulate in all the three dimensions.
So
And
this was just intended to be an eye opener. We can have like more focused sessions, and I will also share the links for the free software.
please, sir, that was wonderful. And I think we should more and more go into it.
Thank you, sir.
Thank you, sir.
Nice presentation, Siddharth. Yes, rightly said by Dr. Bola. It has to be the future. And if you are pre-hand, you are prepared for something that gives wonderful results. Absolutely fine.
Thank you, sir.
And moving on to the next speaker, Akanksha, whom?
Sir,
Aradhana ma'am?
yes, sir. Aradhana ma'am can go next.
Okay. I hope my screen is visible.
Yes, ma'am.
Yeah, okay. After extensive talks of the previous speakers, I will be kind of summarizing the indications for ILIZAROV in foot and ankle. This talk will be especially for the beginners, where we are choosing fixators for few kind of cases, and let us see which cases we can choose. So what is the need for fixator in foot and ankle? The basic need for fixator in foot and ankle is when we are thinking of deformity correction, especially when we want to overcorrect and overstretch the soft tissues and prevent the recurrence. And if we are thinking of simultaneous deformity correction as well as lengthening, or when the soft tissues are bad and we want kind of minimal invasive method to do the procedure. So, as foot and ankle and ILIZAROV surgeons, we will be having cases which come at the last stage, that is advanced stage of foot disease or the negative consequences of previous surgery. So do not hesitate to use a frame as a last resort rather than amputating them. So let us take few examples as we go with the indications. So let us start with congenital. After an extensive talk on CTEV, I will be just briefing that CTEV is one of the indication where we do ring fixator application. One of the case where ring fixator frame was applied initially for soft tissue correction, and then V osteotomy was done to correct the equinus deformity for flat-topped talus, and we got a plantigrade foot, and these are the clinical images. Final image. Let us go with the second example where the frame was applied. So this 24-year-old male patient came to us with ankle deformity. He had history of childhood infection around the ankle and leg. So if we see his x-rays, we can see that the plefond is in valgus, the lateral malleolus is hypoplastic, distal 1/3 of the fibula is very thinned out, and there is evidence of segmental resection of the fibula, which was done to confirm why the fibula was so much hypertrophied, and then this case was sent to us for management of deformity. So in these kind of cases, this patient had recurrent history of abscess in the lateral compartment. So now we have to correct the deformity and give him a normal ankle. We can go ahead with internal fixation as well in this case, but history of previous infection will not allow a surgeon to go directly with internal fixation. So best treatment option is ring fixator. So we went ahead with a frame application and osteotomies. For lateral malleolus, we did osteotomy rule 1, corrected the hypoplastic and hypoplastic lateral malleolus with a bone graft, and supramalleolar osteotomy for valgus deformity at the pylon, and this was the frame, and we got a beautiful correction. So the correction can be very well controlled in a frame than when we do with acute correction with plates. This is the patient ambulating well, we can't even make out which foot was operated. So let us take few case examples of infection. As ILIZAROV surgeons, we should get 1 or 2 infection per month, infected cases per month to manage. So we should be well versed with managing the infected cases. So even in foot and ankle, we do get a lot of infected cases. This young lady with hereditary sensory motor neuropathy, we can see there are multiple discharging sinuses, and these were her x-rays. Amputation was advised in multiple places. Now what to do? We can't do internal fixation in her. So we are forced to do external fixation, that is ring fixator application in her. We debrided, put ring fixator. And in this case, the fixator we are using to fuse the ankle and give compression. So over a period of time, the wound healed well, the sinuses closed. We achieved very good ankle fusion, and she was walking well independently with a walker. Now we can use fixator in infected cases as interim procedure. So we can use it as a stage 1 procedure where we can correct the deformity. This is a case of peritalar subluxation in a Charcot's ankle. And we did deformity correction. Then we did triple fusion at a later date after the infection was controlled. So we can use fixator as an interim procedure as well. Plantigrade foot was achieved and independent ambulation was achieved in this lady. Another case of midfoot Charcot's. Why do we have to apply a frame in this? We wanted to mobilize this lady and we wanted to correct the equinus also in this lady. So this was the sinus on the plantar aspect. We debrided it, did a subtalar fusion, did triple hemisection, applied a frame for deformity correction and initially, and used it as a static frame later to achieve midfoot fusion in this lady. So another case example where mini fixators can be used for small bone infection. So this lady had tuberculosis of navicular where mini fixators were used to distract and keep the medial column. After debridement and in the second stage we did fusion under cover of ATT. So let us take few case examples of trauma. Trauma is another indication where frames are being applied in patients. So this is a patient of Volkmann's ischemic contracture. So we can see the amount of equinus deformity the patient had. So this is very good case example where the frame helps us in various situations. One is soft tissue distraction and another is bony correction. So this patient needed both. So initial soft tissue distraction, we got some amount of correction. Then supramalleolar osteotomy was done and we achieved a plantigrade foot. Patient is walking well, independent, and socially also he is accepted in the family functions. So another example of translational osteotomy where patient did not have a heel fat pad or a sole. So heel reconstruction was done in this patient. Here, very difficult to do a heel reconstruction with internal fixation. So external fixation comes as an indication in this case. So we had to translate the forefoot and midfoot sole posterolaterally over a period of time. It translates really well with the frame. And this was the frame construct and pre-op and pre-correction and post-correction. And patient is walking now. Another example is fresh trauma, that is pylon fractures. If the skin condition is bad, so none other than ILIZAROV fixator will come for rescue, which is very minimal invasive, and we can use olive wires in various directions to give compression of the fragments, and it will heal on well, making the patient ambulant on the first day itself. Other examples of mini fixators, as I had already given for infection, we can use for forefoot trauma and midfoot trauma as well to keep the columns distracted and keep the length in alignment. So another example of malunion in pylon fracture treated with supramalleolar osteotomy as a complication of trauma. So patient achieved a good alignment. So there are few other indications after Cherry sir's talk. So nothing much for me to speak about. Tumor and bone loss around the ankle. Post-burn contracture is another indication for ILIZAROV, or amputation stump lengthening. We have seen a lot of cases of midfoot amputation where TA contracture leads to difficulty in walking in patients. So to give a better lever arm for the patient to walk, you can do amputation stump lengthening as well. Another indication is transverse tibial distraction, very important, especially when the patients have non-healing, chronic non-healing ulcers. So we can consider transverse tibial distraction in these cases where flaps cannot be done or the patient has peripheral arterial disease or atherosclerosis. So one case where I had a complication after the surgery with uh, non-healing wound, did a transverse tibial distraction in this lady, and it went on to heal well. We can see over a period of time the wound has healed really well. So last indication I would like to say is joint distraction. So joint distraction basically done for ankle arthritis or uh, uh, in cases where we are contemplating that arthritis can happen and we want to prevent it. So in this patient of mine, I have done it in a case of osteochondral defect of talus, where treatment was given and patient wanted to ambulate because he was the only person who was earning in the family and he had to go back to work. So I did a joint distraction and gave him hinges at the ankle so that ambulation is not a problem. And for 3 months, the joint was distracted with movement and patient was happy and it went on to heal well. So other indications are metatarsal lengthening, and take home message will be it's a versatile tool, can be used in various conditions of the foot and ankle, but proper planning is necessary. It needs a learning curve. So try with trauma, then with uniplanar deformity, go to multiplanar deformity, and accordingly indications have to be taken as a surgeon. Thank you so much.
Thank you, Aradhana. It was a comprehensive talk with all the aspects covered. Moving on to the last speaker because we're running short of time. Madhura, if you can start sharing your screen.
Good evening, everyone. Thank you. I will quickly share my screen. I am giving a talk on ILIZAROV fixator used for pilon fractures. Can everyone see the screen?
Yes, ma'am, visible.
Okay. So almost all the indications of ILIZAROV have been covered by now, but I would like to give a step-by-step instructional kind of a talk on how to manage a pilon fracture with an ILIZAROV ring fixator. So for a pilon fracture, it is mainly a soft tissue injury with a bony fracture, and we all know that pilon fractures are always associated with swelling and maybe blisters and some maybe even compound trauma. So consideration of the soft tissues is very important. Like in these case, where the soft tissue was not permitting me to do an internal fixation. So we can use ILIZAROV fixator in cases where there is high energy trauma, there is severe comminution of the fracture fragments, there is significant soft tissue compromise, and in cases where the internal fixation has failed or there is infection. There are multiple papers and research articles which tell us that ILIZAROV is a good method for treating pilon fractures. So how to apply the frame in a pilon fracture? So first, the reduction is important, and to fix the pilon fracture with the frame. So the frame can be either a 3-ring construct or a 4-ring construct if we are going for bone transport and corticotomy and lengthening later on. For reduction, many papers also have mentioned that gradual traction, even by hanging the foot down from the table, can give gradual traction and reduce the posterior malleolar fragment. We can use minimal incisions and olive wires to get about reduction of small fragments. And olive wires can give some amount of compression to the fragments. These are certain examples of how olive wires can be placed here in the syndesmosis or in the anterolateral fragment to get about reduction. But in the case of syndesmosis, it is better to reduce the syndesmosis, and then put a screw, a position screw that we do, and use the fixator as a neutralization frame. So this is an example of the frame I had used for a case of infected non-union of a pilon fracture, and she was a rheumatoid arthritis patient on a lot of medications. So I removed all these implants because there was infection, and considered a 4-ring frame in such a way for the oblique fracture. I also put an lag screw through the oblique fracture to bring about compression. So this is how the frame looked. And I put the calcaneal frame also, and I removed the calcaneal ring after 6 months. And she was walking throughout the treatment during this fixator. And after 9.5 months, I removed the fixator, and now she's walking independently without any pain, and she has slight jog of motion at the ankle joint. One other method of treatment is by bone transport, like seen in this X-ray. He was a 44-year-old male, and he had come from another hospital where he was treated with an external fixator, and the local site was clean. It was healed completely by a flap. So I converted it into a bone transport frame with a calcaneal ring, and gradually started transporting. So got a good result with transport of almost 4 centimeter of the 3 centimeter of the bone proximally, and there was good docking at the distal site as well. And 7 months later, all the pin tracks and everything had healed, and this is his latest 1.5-year-old follow-up when he is doing all his farming activities. This was the fixator assembly for the patient, where the R1 was placed proximally for the transporting fragment, and R2 was placed in the midshaft with a wire and a shat spring to transport the middle part. Certain cases, fragment-specific fixation can also be done. Like this case, he was a very old person, a very frail person, and he had this kind of a wound. Still, we tried to take care of the wound to achieve internal fixation, but that was not possible. So I did fragment fixation with a few screws from posterior to anterior, and then put the medial malleolar olive wire, so that the medial malleolus can be fixed very nicely. And here we can see that the syndesmosis also fixed with a screw. So after 6 months, the fixator was removed. His function is good, and he is walking independently without any pain. This is a case Dr. Amar Soni sir has lent me, because it's a very good case of a vehicular accident and a uncontrolled diabetic patient where ILIZAROV ring fixator was used. And these are the sagittal and the coronal, sagittal and the axial cuts, which tell us that the fracture was a very comminuted intra-articular fracture. He put the frame and distracted the fracture site as well as a valgus, added a valgus, and you can see that the ankle is also distracted. There is good union of the fracture after 3 months. And he has removed the frame after 3 months and put him on a brace. And after 3 months, this is the picture, and the patient is walking very well in a painless fashion, and his ankle movement is also very nice. So ILIZAROV fixator is a minimally invasive application. It gives a multiplanar stability and allows early weight bearing. It has a better outcome rather than internal fixators in certain compromised conditions. But there is pain, there can be pin site infection, and there's a lot of psychological impact of the external fixator, because sometimes it can be a very long duration of treatment. Some cases, joint stiffness can also be seen. It has been reported that there are good outcomes with the ILIZAROV fixator, and early mobilization is also possible. It is better than amputing a limb to give trial of ILIZAROV at least once. So in conclusion, I would like to say that ILIZAROV is a valuable tool and can be used for stable fixation and soft tissue preservation. Thank you.
Thank you, Madhura. It was a nice presentation and stepwise learning for the members who are
Thank
new
you.
to this technique. By this talk, we come to an end to this webinar, and we'd like to thank Helio Cunha again for taking his time out from the busy schedule to be with us today. And
Thank you.
we shall like to have more such interactions of Brazil ILIZAROV Society with ASAMI India. And Akanksha, anything else you want to add?
Just want to thank you all you guys.
Thank you.
And we'll try to invite you to our webinars.
Surely we'll be there.
Thank you, sir. Sir, Amar sir has joined. I would like Amar sir to say.
I'm very tired.
No, thank you everyone. Sorry I joined late, and thank you everyone for joining this webinar. And we'll be continuing this webinar and monthly case discussion series. And thank you, Dr. Cunha. Thank you all presenters, Cheriyan sir, and Aradhana and Siddharth and Madhura, all. Thanks all.
Sir, you're on mute.
So let's end this meeting today and meet
Yes.
later on with Central Zone's webinar. Pranav would be handling it. I think so it's the last week of the September. Till then, good night.
Good night. Good night, everyone.
Thank you, sir. Bye-bye.
Good night. Bye-bye.
Thank you. Thank you
Good
all.
night. Thank you all.